I wanted just to pick up on one specific sign, and Homa had Daniel demonstrating it really quite nicely. It's just so important that this is not missed and not treated as just somebody with some knee pain, have some physiotherapy, give this time and let's see if it gets better. A locked knee. The name itself is somewhat misleading. It implies that it's a knee that doesn't move, but that's just not the case, and it can be much more subtle than you may think. Here's a video of a patient that I did. I think it was last year.
To lift your leg up in the air, and straighten it out. Straighten out your knee as far as you're comfortable to do it.
So start to feel tension.
So put it down now and see how straight you can get it.
So
you'll see
like that. Reverse like that. So you're about 20 degrees maybe.
So this is quite an obvious limit to his extension, and as Homa implied, it's actually not always as clear as this. But you'll note with he has a bucket handle tear to his meniscus, but actually his knee is not massively swollen, and his inhibition at that point. Why is he limited to this much? It's pain that's inhibiting him. I took him to theatre after an MRI scan to confirm the diagnosis, and so when he's asleep, the knee comes out much straighter, but it's still not straight, and this is how it often looks. So it's very important to examine the other side and see what's normal for that patient. 5 or 10 degrees of not full extension is what a locked knee often presents as, and an urgent MRI scan is the next priority. And the sign that we're looking for is what we refer to as a double PCL sign, and that's it just there. You see, this is his posterior cruciate ligament, and it looks as though it has a neighbour following the same trajectory. This is his meniscus, which is flipped into the notch, and it's the meniscal tissue that sits in this zone that prevents his knee coming out straight, and that represents an urgent problem that, as an orthopaedic surgeon, we want to be addressing as early as possible.